Hello and welcome to the CoreNet Online 2022, where we discuss learnings on resilience and resurgence from 2 years of COVID-19 in India. In today's session on inequalities and exclusion, we'll hear stories and experiences of how millions among the general public were prevented from accessing, using, and maintaining quality lifestyle. The wealth gains of the world's 10 richest people could pay for enough vaccines for everyone and fill financing gaps in climate measures, universal healthcare, and social protection. Yet, over 160 million people worldwide suffered exclusions and inequalities during the pandemic. To better understand this inequality, we spoke to Dr. Santanu Pramanik, Senior Fellow at NCAER and Deputy Director of the National Data Innovation Center.
Although this disease has affected both rich and poor, we know that there's no escape of any socioeconomic demographic group. But if we think about the impact of the disease, that definitely has affected mostly the poor and vulnerable population. Not so much. Of course, there are still losses of life happened even at the higher economic state, etc.
It is important for us to understand how different people get scarred uniquely based on their position in the economy and society. In 2001, Vijayashree defined scarring as the negative long-term effect that unemployment has on future labor. However, for the purpose of this plenary, we have widened the original definition of scarring to focus on a variety of economic, health, and educational shocks induced by COVID-19 as we examine inequalities in the experience of scarring by gender, class, residence, and other vulnerabilities. Scarring from income and job loss during this period led to 3 key challenges for individuals and families: inability to make payments, inability to access education, inability to access care.
There is, because we have seen huge drop in employment during the first lockdown as well as during the second lockdown. But there was recovery within short time frame after both the lockdowns. But what happened that people sometimes had to settle for less remunerated jobs, and maybe requires much more physical or manual labor, or in general lot more effort than they used to put earlier.
We spoke to Alpana, Bera, a domestic help in Delhi. Prior to the pandemic, her husband worked in a canteen, and their combined income allowed them to offer a certain lifestyle and schooling to their son. However, when the pandemic hit India, her husband lost his job, limiting their family income. She shares more with us from her son's experience during this period.
उस टाइम क्या है, उसका पापा के पास बड़ा फोन था, क्योंकि हम लोग जहाँ रहते हैं वो गली के अंदर वो नेटवर्क प्रॉब्लम का बहुत दिक्कत था, तो वो ऑनलाइन क्लास ज्वाइन नहीं कर पा रहा था। तो इसी वजह से मैंने भी इतना वो ध्यान नहीं दिया, चलो ऑनलाइन क्लास कैसे करेंगे, बच्चे आ नहीं रहा था, डिस्टर्ब आ रहा था, पता नहीं चल रहा था। अब बेकार में मैं ऑनलाइन क्लास ज्वाइन करके रखूंगी और पब्लिक में पैसे डालना होता है, नहीं तो ऑनलाइन क्लास ज्वाइन नहीं करने देगा मैम। मुझे तो ये पता है, मैम बार-बार मुझे बोल रहा था पैसे डालो, कि तो एक्चुअली इनकम नहीं था दीदी, तो मैं कैसे डाल सकूंगी बताओ।
Alpana and her husband found it hard to pay their rent and were forced to eventually remove their child from a school they could no longer afford. 2 years of the pandemic and 2 skipped classes later, her son is now enrolled in a government school. Prolonged school closures have had serious implications on children across the country that extend beyond learning. For many, disruption to in-school education meant increased child exploitation, lower nutrition with constrained midday meals, or social and emotional issues. Moving from one challenge to another, we try to understand the challenges that already marginalized population faced in accessing healthcare through our conversation with Dr. Vijayashree Yellappa, a medical practitioner and faculty member at the Institute of Public Health in Bangalore.
TB is such a diagnostic heavy disease. I'm not sure how much you know about TB because even recognizing the symptoms of tuberculosis takes some time. Unlike typhoid and malaria, where you will have acute fever. So, what happened in 2020 is that people were struggling to understand whether it's a TB or it's a COVID, because COVID symptoms and the TB symptoms are so similar. This created a lot of confusion. Think about the patients, marginalized patient. It could be laborers, it could be migrant, and people had lost jobs, you see, and they go and seek care, but they'll be asked to get the COVID test. It is such an enormous out of pocket expenditure. And then on top of it, they have to go and get the TB test done. I heard from patients, they were admitted in the quarantine and they see the patients on the right and left, they were dying and dead bodies were all there. So there were a lot of stigma attached to being quarantined. I take an example of one patient, a slum dweller, Sanskriti. The patient comes to me with a history of cough for 2 weeks. I think it's tuberculosis. So I asked them, okay, go and get your sputum examination done. But the patient does not know where is this laboratory is located, whether they should go to the government hospital, whether they should go to the private hospital. If it is a private hospital, then they have to go and actually search for that lab. That itself is a lot of effort, you see. And if it is a woman, the burden is much more because she needs to be accompanied by a male person and she needs to also take permission from the family. So the patient will have to go back home, come again the next day, stand in the queue, collect the report, and they have to come back to me. And they have to see whether I'm available or not. TB was one disease which was very similar to the COVID. And our staff, especially the laboratories or paramedical staff, knew how to collect the sample. And suddenly the policymaker realized that we have a wealth of qualified HR from the TB programs, and all of them were diverted for COVID work. The TB prevalence survey report is out, where ICMR, Indian Council of Medical Research, and WHO did the surveys to know what is the burden of tuberculosis, which has reported that 64% of the TB patient had not sought care. Okay, so it calls for engaging the community because patients do not know what is TB and they don't know what are the symptoms. I think it's high time that we include the Panchayat Raj, we include the community to eliminate TB from India.
The migrant population was identified as one of the most vulnerable groups at the very start of the lockdown in India. They had little to no money, they were struggling to return home, and were pushed into further marginalization. Varun Aggarwal, founder and managing director of India Migration Now, talks to us about how our welfare systems require a rethink going forward.
Over 200 million people, 250 million people have, fallen back into poverty during the crisis because of the pandemic, the lockdowns, and the impact on jobs and whatnot. When we think about migration and this role in poverty alleviation, we think about also the corollary of it since the crisis. If there are not enough jobs, you have a situation now today where many people have fallen back into poverty. And like I said earlier, they have food insecurity. And I think that's something to highlight. That is being reinforced again and again, right? Second, migration patterns have changed. People who used to migrate, some have stopped because of the reasons of what happened first 3 months crisis. People who never migrated are migrating because, well, it's bad rule economy also. And people who are migrating have maybe chosen to migrate closer to home or different location. So migration patterns have changed. The World Bank is supporting the World Bank, and this is they've seen in multiple countries, that the nature of poverty has changed in the last 20 years. How? The assumption the governments have been that poverty is rural and static in nature. If you look at the programs, the way the registration works, that's how they design it. Increasingly, we know it's urban and dynamic, mobile. And that's a big shift. So your programs, your welfare systems need to adapt. We still have this place-based mindset. We pick a village, do everything we can within that village. The reality of that village is much more beyond that village. If you talk to governments, I think it's worth sort of the axiom of the government is that we want to stop migration. We want to do development at source, and that will stop migration. That's the fundamental assumption of something like Manrega. Manrega has an explicit goal to say that we want to stop distress migration.
With the poor and the vulnerable bearing the brunt of it, the pandemic is dealing a severe setback to ending poverty and boosting shared prosperity. At the same time, as India is beginning to chart its recovery, there is also an opportunity to redesign our economies to be centered on equality. There is a need to invest in strong and proven public measures to reduce inequality and to boldly shift power in the economy and society.